In terms of the rationale for this study, it's important to understand that up to 18% of patients with colorectal cancer develop pulmonary metastases at some point during their course of disease. And detecting these nodules early enables us to provide curative resection. However, there exists wide heterogeneity in terms of practice patterns for surveillance imaging of the chest after curative resection of colorectal primary cancers. And we thought it would be important to try to provide some evidence-based rationale for the timing at which people receive imaging of the chest after they undergo surgery for their colorectal cancer.
What we did was a retrospective analysis of patients with colorectal cancer who underwent resection at MD Anderson. Within this cohort, we then identified patients who developed a colorectal pulmonary metastasis. And because of this multidisciplinary inclusion strategy, we were able to collect data from 1,600 patients in total. We then used multivariate modeling to investigate clinical, pathologic, and genomic factors that might inform the likelihood of developing early pulmonary metastasis. We found that patients with resectable colorectal cancer who required perioperative systemic therapy, who had an elevated lymph node ratio and a KRAS mutation, were at risk of developing a pulmonary metastasis within 3 months of their colorectal resection. This group of patients should have early post-colorectal cancer resection chest surveillance.
Ultimately, beyond validation in an external cohort, our eventual intention would be to provide an algorithm for an evidence-based risk-stratified recommendation for chest imaging timing for patients with colorectal cancer after undergoing resection of the primary tumor, so that the healthcare professionals and the patients have a clear idea of the ideal timing at which those patients should undergo repeat imaging of the chest to look for pulmonary nodules in an early fashion if deemed appropriate based on their risk.